speakers are going to be Dr. Divi Kornick, Dr. Alvise Berti, and Dr. Marta Mora. They have all done some training at Mayo, and they're working in their respective, well, Marta's still at Mayo, and Divi practices in breast, and Alvise practices in Trento in rheumatology. I won't get into their details. You guys have their bios here, so I can give them some more time to speak to all of you about some of the updates. Welcome. Thank you guys for joining us all the way.
So, morning everybody. I will report the news from EULAR of 2022, scientific news. So, and I'm gonna focus on GPA and MPA. So the granulomatosis with polyangiitis and microscopic polyangiitis. As you know, these are essentially two forms of the same spectrum of disease, with granulomatosis with polyangiitis involving mostly but not only the respiratory tract, whereas the microscopic polyangiitis involve very often kidney, but not only. And that's why these are, as I was mentioning, the spectrum, the two diseases of the same spectrum. So to some extent, that's why we pull together the patients for trials and we study new treatment in this sense. So what's the news for 2022? So for sure, we developed new criteria, EULAR ACR criteria to classify the disease. And I will also speak about the new guidelines of 2022, the EULAR guidelines, the European guidelines, and then the new therapies that emerged last year. So let's start with the classification criteria. The question is why? Why do we need classification criteria, new classification criteria for vasculitis? Because actually, since 1990 ICR criteria, some of the vasculitis were not included in this criteria, like MPA specifically. So that's why in the vasculitis community, there was the need to develop new criteria that involve it as well. And also because in the last year, we started to use ANCA often and often, so the test ANCA, which helped a lot for the diagnosis. So for this reason, the scientific community thought that it was good to have new classification criteria that you can see here for GPA and MPA. So what's the difference compared to the previous one? These are scores, as you can see. So it means that the patient that have to be enrolled in clinical trial needs to have a score of 5 to be classified as GPA or MPA. And this is very helpful. And I was saying not for diagnosis, because these are not diagnostic criteria. These are classification criteria, which means that is what we need to be sure that the patient really have that disease, to include him or her in the trial and to really have outcomes, to measure the outcomes of the therapy. Then last year emerged also, we actually wrote the guidelines. I was part of the panel. It was a great experience, a pleasure to be there. We essentially guidelines kind of sort of help doctors to manage the disease and put together its evidence-based guidelines. So it means that we do systematic literature review, and then we kind of, based on the evidence, we try to put some sentence that help us to guide the treatment and the management of the disease. And what emerged in these guidelines is that for Rituximab, for the treatment of the severe disease, is the best option if you have a relapsing disease, while for induction in general, at least with the evidence that we have now, it's still equal the efficacy of Rituximab with the cyclophosphamide. It's anyway different, as I was mentioning, and if you have a relapsing disease. For relapsing disease, Rituximab would be better. It's better, actually. It doesn't necessarily mean that a relapsing patient, have only Rituximab as a single option. This is something that I'd like to specify, that this is something that it's guidelines, so it means that it helps us to take the decision, but it's not necessarily, it doesn't necessarily mean that we have to do like that, because the therapy is tailored on the single patients. Also, there was enough evidence to recommend Rituximab over cyclophosphamide or methotrexate for the induction of remission of non-severe disease. This is different as compared to the previous guidelines in which methotrexate was recommended. And then there was a very large trial, as you know, PAXIVAS trial, that showed that the glucocorticoid regimen could be reduced to induce remission, and I dedicated a slide to that, and that they use plasmapheresis that have to be considered in severe disease only, and in renal severe disease only, not in alveolar hemorrhage, and then Avacopan showing the benefit of using Avacopan. But let's speak about glucocorticoid regimen first. So PAXIVAS trial show that we can use less glucocorticoid for induction of remission, and as you can see from the table, the dose of glucocorticoid could be reduced starting already from the second week of induction. Half of the dose, as you can see. I just circled one of the weight range to facilitate the comparison. You can see in the first week, for instance, the dose is 60 milligram per day of glucocorticoid and 60 milligram per day in both regimen. But then starting from the second week, in the reduced dose regimen, it's 30 milligram instead of 60 milligram. So it's not about the dose, but the concept. We can reduce the dose of glucocorticoids and obtain the same results. Then also another news was about plasma exchange. You know that the trial, it's from 2020. It shows that plasma exchange didn't really help in all the patients, severe patient with AAV, but then there was a meta-analysis, which means that we pulled together all the results of all the trial out there on plasma exchange, and this showed that perhaps a little bit in severe cases, using plasma exchange could help to keep a good, to avoid renal insufficiency at 12 months. So that's why the guidelines decided to still give this indication only in severe renal cases. So for those patients that have a severe renal disease, it's not recommended, but it may be considered to use plasma exchange for induction of remission. And then Avacopan actually, it's already labeled and approved in the United States. It's not really the case in Europe, unfortunately, but we are getting there. And as you know, it's really a drug that could be add on the standard of care, and these help to reduce the glucocorticoid dosage significantly. So that's obviously is recommended. It may be considered and have to be considered in these patients. There are also news from EULAR regarding the maintenance of treatment, as we were saying yesterday in this room. Rituximab, but at a lower dosage, it could help for the maintenance, and it actually has been shown to be superior as compared to conventional therapy, as azathioprine or so. And then there has been evidence recommending to prolong a little bit the maintenance of treatment. So there are trials showing that if we don't stop at 2 years, but we go longer, it's probably better for patients. What's new? So what's the emerging therapy for ANCA-associated vasculitis? The trial that has been published in 2022 is this trial that you can see here. It is about 188 patients, 7 countries, 29 centers, comparing the use of Rituximab, 1 gram every 4 months, as compared to standard of care for the maintenance of treatment, which is azathioprine. And as you can see from the curves represented in the slide here, there are a significant proportion of patients that are still in remission, the blue line, with Rituximab, as compared to azathioprine. So this study really confirmed that Rituximab, it's probably better for maintenance of remission. But you can also see from that curves that relapse still occur, even with Rituximab. So, and especially when we stop it. So there's still work to do. That's what I mean. And what about the future? And this is my last slide. The future, we have trial that has been published recently, and we also have trial that are still ongoing but the future is probably on B cell. B cell, you know, it's one of the leukocytes, the white blood cell, that produce the antibodies, and for those that have ANCA-associated vasculitis, they produce a proportion of those B cells produce the ANCA, so the autoantibodies that are those that cause the disease. So that's why we are really focused on targeting the B cells for the next trial. And this year have been published Alemtuzumab, which is actually a molecule that targets CD52. Then it's a good drug, but it has a little bit of collateral effects, and for safety reason, I'm not sure it's going to be approved soon. We heard yesterday from Dr. Merkel that Abrogate trial finished the recruitment, and we expect to see some results soon. Abrogate trial is the trial that study anti-CTLA-4, a modulator of the BT cell interaction, and then there is Convivas, which is also a trial that combines Rituximab and another anti-B cell drug, which is Belimumab, which is still ongoing. And we are expecting to have new trial on other anti-B cell therapy or CAR T cell therapy. You probably heard about that. So it means that it's a cellular therapy targeting specific target, and in this case, targeting the B cells. But we have nothing out there yet. Okay, so I'm finished with that part, and Marta, probably you want to go on.
Hello. Thank you very much for the kind invitation and for the kind introduction. My work is highly facilitated right now after Dr. Berti's presentation, because he guides you through the principles of the advances. I'm just going to try to explain to you why EGPA is a little bit different, and why probably we are still a step behind on the treatment and on the research. So EGPA is a small vessel vasculitis, as MPA and GPA, but it has a particularity, which is you will have eosinophils in the blood vessel wall, infiltrating the blood vessel wall, and this is going to have consequences on the clinical presentation and on the management of these patients. As you can appreciate, EGPA can have several clinical manifestations, and this is going to be dependent on ANCA also. If they are positive or negative, they will actually interfere with the extent of the disease and with the organ involvement. In several series, as you can appreciate from Europe and from the United States, the symptoms and the organ involvement varies, but typically lung involvement and respiratory symptoms are present, and also involvement of the peripheral nervous system can be also very frequent. The biggest problem in GPA is that the clinical presentation goes in phases that sometimes are not identified, and there is a delay on the diagnosis. So therefore, there is a lot of heterogeneity in these patients, and so it's difficult to gather them in particular phases of the disease, because it's a spectrum. I wanted to just go a little bit over the epidemiology, just to show you that EGPA is much less frequent than GPA and MPA, and also in terms of ANCA positivity, there is a higher frequency of patients that are ANCA negative, and this is going to interfere with the selection of patients for clinical trials, and therefore for the testing of drugs. Also, and this data comes from the classification criteria, and as you can appreciate, patients with EGPA, when they were compared with other type of vasculitis, they were younger, they had less kidney involvement or better renal function, they were most frequently MPO ANCA positive, and they had eosinophilia in comparison to the other vasculitis. So this will be important to then define particular classification criteria that then will help us to better select patients with EGPA to be included in a more homogeneous way in the clinical trials. And so after confirming vasculitis and after verifying what is positive, then obviously what's not present more frequently, it's going to have a negative impact on the classification criteria. So essentially, the EGPA, as the other MPA and GPA, are chronic relapsing remitting disease, and they follow the same pattern in terms of treatment. We will have an induction treatment and a maintenance treatment phase. But in this case, we have other pathways to address because we have the eosinophils that are important players on this disease, and particularly we have the anti-interleukin-5 therapies that we can use to treat EGPA. As you can appreciate, this is a table that summarizes the main studies published on research on clinical trials for EGPA. And essentially, cyclophosphamide was tested, and also mepolizumab on the mirror trial, anti-interleukin-5. But essentially, apart from those drugs, a lot of other therapies are under investigation, but they are not still available for use. So essentially from the EULAR guidelines, what it came about for EGPA was actually allowing a better and a more organized approach to the treatment of these patients. Essentially, now in a patient with active EGPA and with a not organ or life-threatening disease, mepolizumab is considered to be the best option in combination with glucocorticosteroids. But if the disease has organ or life-threatening, or is organ or life-threatening, then cyclophosphamide is preferred, and there's crescent evidence that Rituximab can be used as well. However, the RIOVAS trial is still not ongoing, but we are waiting for the results. Then after this phase, it actually comes the problem, because EGPA is a very relapsing disease, and so taper the glucocorticosteroids is difficult and is very individual. And then obviously that's why there's needed a maintenance of remission phase. And at this point, what came about from the guidelines is essentially that you can use whichever treatment that was already explained before, and also mepolizumab and rituximab for achieving sustained remission, which is the challenge in EGPA. So I question here actually what's next, and probably what needs to be improved. And I think differently from GPA and MPA, corticosteroid sparing is not yet a reality. These are in the left side of the screen. You can see the data from the Pexivus trial, or based on the Pexivus trial for the glucocorticosteroid doses, but this was not tested in EGPA, so this kind of sparing, it's probably not a reality for patients with EGPA. And also Avacopan, that was proved to be favorable for sparing the effects of glucocorticosteroids, was not tested in EGPA yet, but it's probably something that we all await. And then in a much distant future, probably, personalized medicine, because we know that there's many differences in EGPA patients, particularly in what concerns patients that are MPO ANCA positive or negative, and this reflects in different clinical manifestations, and is also going to probably reflect in different responses to treatment, and this interferes with the patient selection for clinical trials, and that's why we also have some paucity of data, although from the last guidelines there was a big evolution on a standardized approach of these patients. moving forward, I will introduce Dr. Divikornek, that is going to talk about large vessel vasculitis and PMR.
Thank you. So hi everybody, I am in charge of reporting on what was said at EULAR, and I just realized that we didn't explain what EULAR is. So it's one of the two main conferences worldwide in rheumatology. So there is the ACR conference in the US happening during fall, in November usually, and EULAR is a European rheumatology conference, and it happened 1 month ago in Milan, in Italy. And so we were there with Alvise and Marta, so that's why we are reporting on what happened there. The conference was quite intense with many different communications about vasculitis. And so I just picked up a few important things that were told there. And first of all, concerning large vessel vasculitis, a few slides on imaging, because we had new recommendations from EULAR on how best use imaging in large vessel vasculitis, so in GCA and in Takayasu. So it's a very busy slide, but basically the important message is that when you suspect GCA and you have an abnormal ultrasound, you can make the diagnosis without performing any other invasive test. And so in GCA, the first choice imaging to make the diagnosis is ultrasound. And if it's not, if it doesn't allow to make a precise diagnosis, you can use other imaging such as PET-CT or MRI, for example. And in Takayasu, the main imaging modality that is recommended is MRI of the arteries to follow to diagnose the disease first and then to follow. I will be really quick on that. So that's pretty pictures from Milan, so from the Duomo place. And I will just speak about PMR, so Polymyalgia Rheumatica, which has been a niche for research for a really long time, and the research is becoming active. I think it's something that some of you faced. Among the symptoms of GCA, it's one very debilitating symptoms with those pains in the girdles that can be really, really bad. And so we are starting to have specific research done on PMR to better understand what happens on the site of the pains. So for example, in this study from the Netherlands, the investigators performed some biopsies of what we call the bursae. It's the places that concentrate the inflammation in PMR. And so it's really the first data we have on the tissue abnormalities in PMR. And so we know that among the different immune cells that get into the tissue and probably create the inflammation, a type of cell we call monocytes are really important. And in this study, they showed that through what we call cytokines, so GM-CSF and interferon gamma, were leading to the activation of macrophages that in turn produced IL-6. And so it's a bit complicated, but those three cytokines are targets for therapies. So for example, IL-6, you've probably heard about it because we have drugs targeting IL-6 and more specifically IL-6 receptor. So the main one is Tocilizumab that was proven effective in GCA a few years ago. And we've been organizing clinical trials specifically for PMR recently. And the first one published was this one, run in France, where we tested Tocilizumab versus placebo in corticoid-dependent PMR patients. And we proved that Tocilizumab is effective as a steroid-sparing agent in PMR specifically. And so now we are performing quite a bit of new analysis from this data set to better understand the role of Tocilizumab in PMR. And the parallel trial that was performed and communicated last year at ACR evaluated another IL-6 receptor blocker called Sarilumab. And so that was the SAPHIR trial, and that also showed a really impressive efficacy in PMR. So we do have new treatment options for these patients. And so this study will probably lead to the labeling of Sarilumab to treat PMR patients very soon. And a last slide about imaging, because for those of you who went through PMR, you know that we don't have specific diagnostics tests to recognize the disease. And so we are sometimes using imaging tests, so mostly ultrasound and PET-CT. And in this study, so it's a lot of numbers, but what we can learn about it is that those tests work really better if patients are off therapy, so we have to perform all the diagnostic tests before starting steroids if possible. They perform definitely much better in treatment-naive patients. So that's what I just wanted to say. Many other things happen in Milan, but we will not probably capitalize on that for tonight. Thank you very much.
Thank you guys for a wonderful presentation. I know it's really hard to recap an entire meeting in 30 minutes, but what's exciting about that is that we have so much collaboration between our European colleagues and the Vasculitis Foundation and researchers and practitioners here. And it's interesting to see some of the differences in practice patterns there and just sort of look at how we do things similarly but differently also. So it was really nice to hear some of those updates. If people have questions, you're welcome to bring them up. Otherwise, I'm just going to ask for a few questions up here, but I don't know if questions came in on the computer or not. I don't want to take up the time if there's actually patient questions. Yes. Do you find that there are, thank you, that there are sometimes discrepancies between EULAR findings, EULAR guidelines and ACR guidelines? And I know maybe each of you can answer that within the disease state that you talked about. Does that work? Yeah?
I'm going to start.
Yeah, Alvise.
Yeah, so there are some difference thinking about GPA and PA. For instance, one of the differences is that Rituximab in ACR guidelines is considered preferred in all the cases for induction of remission, whereas in EULAR guidelines, it's considered to be equal to cyclophosphamide for induction of remission, except for relapsing disease in which it's supposed to be it's better, actually. So it's just about, this is probably one of the main differences. Why that? The reason is that from a methodological perspective, and you may add something maybe, since you were in the panel of the ACR-VF guidelines, they both start from systemic literature review, but then the methodology that it's used is a little bit different. This may lead to slightly different results. Conceptually, it's not really different, but this small difference might be driven to the methodology that has been used to obtain evidence-based guidelines.
Yeah, I agree. I think one of the main differences is what Dr. Berti just mentioned. In terms of rituximab is equal to Cytoxan or rituximab is preferred. Again, these guidelines are meant to guide people in clinical practice. They're not set in stone. There are a lot of reasons that we may choose to do something outside of the guidelines in an individual patient. So, there are patients where I would start them on cyclophosphamide as opposed to rituximab. It's just a matter of taking every specific person and what's going on in their body and their system, what their presentation is. But in terms of why the guidelines differ, partially it's the timing of when they're released. So we can only include whatever trials have been published up until the point where we are reviewing the literature. So that's going to influence a little bit of the differences in guidelines. And then, yeah, of course, there are methodologic differences occasionally in terms of what we include and don't include to try to create the guidelines. You guys are all well aware these are really rare, right, diseases. So there are not as many huge studies that are randomized controlled trials that can provide us very clear answers. And that's why we have to navigate a little bit to get what answers we can. So we can go on. Dr. Cornick, do you want to tell us what are some of the differences between, EULAR and ACR with large vessel?
I think that overall they are very similar, and the patients are treated very similarly in Europe and in the US. Globally, we use the same drugs, for the same patients. So the differences are very minor, so it's small differences, and it's, again, as my colleagues said, very technical, and the reason of those discrepancies are mostly methodological, so how we get to the consensus to create guidelines. And guidelines are guidelines. They are used to guide the physicians to make decisions. They are not rules, and so each physician has to interpret the guidelines for each patient, so in this shared decision making. So I don't think it's a huge problem or an issue of slight differences between the different guidelines in Europe and in the US. And we are clearly moving forward common guidelines. So for example, we are speaking about the classification criteria, how we define the disease. And you saw that most of the classification criteria now are ACR/EULAR. So actually they are common and they are exactly the same between Europe and the US.
Yeah, which will allow us for enrolling in larger multi-center clinical trials, across all the countries. One difference I will say though, for large vessel vasculitis, there is more expertise in using ultrasound in Europe than there is here in America. And so that is one difference in terms of our diagnosis. We tend to use temporal artery biopsy as our first line because it is very user dependent. And so if you're not really well trained in how to use that ultrasound, you could miss a diagnosis or diagnose it wrong. So we tend, in the US guidelines, it's to use biopsy. The Europeans have more ultrasound training, but we're learning, so. Go ahead, Marta.
Actually, in EGPA, there's a couple of differences, and I think these are mainly related with the timing of publication, because the ACR 2021 guidelines, which I guess that's what the question alludes to, were published in 2021, and these EULAR guidelines in the beginning of 2023. So in the ACR guidelines, the management of patients of EGPA patients was divided between severe and non-severe patients for remission induction. And that contemplated, in patients with non-severe disease, it contemplated the use of methotrexate, azathioprine, and mycophenolate as a remission induction regimen, which is not what the guidelines from EULAR actually now advocate. In the guidelines from EULAR, the patients are separated in patients with life-threatening or non-life-threatening, and as I showed to you, only mepolizumab for non-life-threatening and then cyclophosphamide or rituximab are actually recommended in the remission induction treatment. And that's one of the main differences. The other difference is that on the remission maintenance phase, actually, in the ACR previously, they would, and because of the evidence until that time, they would recommend other treatments, meaning mycophenolate, azathioprine, or methotrexate for the remission maintenance phase, whereas at this point in the EULAR guidelines, they recommend rituximab or mepolizumab as also on the maintenance treatment, whereas in the ACR, they would state that the other drugs were favored in comparison with rituximab. It's interesting that this only tells us that in about a year or a year and a half, there was a lot of research results, or not necessarily clinical trials, but also other kind of research that actually helped the field to adjust and integrate new data for the recommendations, EULAR recommendations.
Thank you. We'll just end with one quick question. If somebody has, we'll say, a small vessel vasculitis, could they cross over to getting another type of vasculitis? So is there, do you know of cases where people go from small to large vessel involvement, or the other way around? Sorry, Alvise.
Well, yeah, there are reports in which there might be aortitis in ANCA-positive patients or stuff like that. It's not very often. It's much probably, so it's a little bit more frequent to move from a diagnosis of MPA to GPA maybe, or within the small vessel, because sometimes the presentation is not so clear. But it's, I would say in general that it's quite rare.
So thank you all for being here.